Good afternoon, class. I am Dr. Sanoria and I have been tasked this afternoon to discuss on the mediastinum, which is a part of the thoracic cavity. The mediastinum is just a potential space. So what do you mean by saying that it is a potential space? It can be, I move this. Wait, just a moment. So your mediastinum, okay. So here we go. The mediastinum is a movable median partition in the thoracic cavity. It is a potential space, meaning to say other structure can go into it or occupy that space, just like if you have a mediastinal tumor. Now, there is this is bounded laterally by the lungs and the pleura, which is the covering of the lungs. Then superiorly, you have the root of the neck. Then inferiorly, you have a diaphragm. So meaning to say, these boundaries just show that it is just a very small space that can accommodate the heart and other structures. So there are two divisions of the mediastinum. You have the superior and inferior mediastinum, with the superior mediastinum smaller compared to the inferior mediastinum. Just that is why the inferior mediastinum is further divided into three. So we go first to the superior mediastinum. It will extend superiorly, anteriorly from the suprasternal notch to the posteriorly to the anterior border of the first thoracic vertebrae. Then inferiorly, it will extend from the sternal angle of Louis to the anterior border of T4 vertebrae. So meaning to say, the extent of the superior mediastinum is just from, if posteriorly, it will be the boundary, or it would be bounded or localized by the first thoracic vertebrae to the fourth thoracic vertebrae. Then anteriorly, it will be to the from the suprasternal notch of the sternum to the sternal angle of Lewy, to that elevation where it will coincide or approximate also the position of the second rib, so sternal angle of Lewy. Then the border, anteriorly, you'll have the manubrium sternae. So that is from the suprasternal notch to the sternal angle. That's the manubrium sternae. Then posteriorly, it will be bordered by your T1 to T4 vertebrae. Now, there are several contents that will pass through the superior mediastinum. These structures will not be limited only to the superior mediastinum, but it can also occupy the inferior mediastinum. So you have the thymus, which is we could say a structure which is not always seen, because as you grow older, the thymus will disappear. But there are some whose thymus will persist. Good for them. They will have a good, they will have a good immune system because they will have many secretions coming from the thymus. Then you have the large veins, which are your inferior and superior vena cava. And then also I think the brachycephalic. Then you have the large arteries, which are basically the ascending and the arch of the aorta. Then you have the trachea, the esophagus, the thoracic duct, and the sympathetic trunk. Now, another division is your inferior mediastinum. It will extend superiorly from the sternal angle to the anterior border of T4. So the superior extent of the inferior mediastinum is the inferior extent of the superior mediastinum. Then inferiorly, uh, it will be extending from the posterior of the diaphragm to the anterior border of T12 vertebrae. So you can see here that the extent of the mediastinum is from T1, posteriorly it will be from T1 to T12 vertebrae. Then the inferior mediastinum will be bordered anteriorly by the body of the sternum, which is below your manubrium sternae. Then posteriorly, it will be bordered by your T5 to T12 vertebrae, because you have to remember the superior mediastinum, the lower or the inferior border is your T4 vertebrae. Then the content here, you will see that there are repetitions of contents that is found in the superior mediastinum and the inferior mediastinum. We have met the thymus in the superior mediastinum. Then we have met the esophagus. Then the sympathetic trunk. Did we met the thoracic duct in the superior mediastinum? Ay, hindi na. Then the contents and the inferior mediastinum, which is not seen in the superior mediastinums, are your pericardium, your descending aorta, the heart, the phrenic nerve, which is the nerve supply to the heart. Basically the diaphragm. Then, of course, we have seen this, the thoracic duct and the sympathetic trunk in the superior mediastinum. As I have said earlier, the inferior mediastinum is bigger, so that there is a further subdivision, which is your anterior mediastinum, the space between the sternum and the pericardium. Then you have the middle mediastinum, which is occupied by the heart and the pericardium. This will be the focus of our discussion. The content of another focus of our discussion, which is the content of the middle mediastinum. Then the posterior mediastinum is the space between the pericardium and the vertebral column. What is the clinical implication of having this mediastinum? Infection in the deep structure of the neck may affect the mediastinum through the loose connective tissue that is continuous between the root of the neck and the thorax. You call this as your mediastinitis. So an infection of the mediastinum is called your mediastinitis, and this is because the infecting organism might go through the loose connective tissue, which is separating the root of the neck and the thorax. So another important thing about the presence of your mediastinum is that there will be pressure effect on the vital structure of the thorax, which may be exerted the mediastinal tumor. Diba? I said earlier that the mediastinum is a potential space wherein new growth can go there, and this would have a pressure effect on the vital structure of the thorax, meaning the lungs and the lungs and the heart. So this is an illustration of the mediastinum. So your mediastinum will extend from your posteriorly from your first thoracic vertebrae down to the 12th thoracic vertebrae. Then anteriorly, the mediastinum will have a shorter border, because it will be on the anterior border, it will be bounded by this is your sternum. This is the manubrium sternae, and this is the body of the sternum. And here you have the sternal angle of Lewis. It's an elevation. Remember in the lecture of Dr. Gasco on the thoracic bones. So you have here in the heart. So this is your superior mediastinum, and below that your inferior mediastinum. And then you have the further division of the inferior mediastinum, which is your anterior mediastinum, then the middle mediastinum, and the posterior mediastinum. So this is just an illustration of the content of the the thorax, which is occupied by your mediastinum. So you have here the heart and also the vessels that will come in. And on the dark side of the dark background is the lungs. Now we go to the heart. The heart is located in the middle mediastinum, and this is enclosed by a sac that will not only envelope the heart, but also the great blood vessels that will come in and out of the heart. Now your heart is located in the middle mediastinum. This is related to the body of the sternum. So posteriorly, you have, anterior to the heart is the body of the sternum, and also the second to the sixth costal cartilages. So you can see that the heart has a bony protection, which is your sternum and the costal cartilages. Now the pericardium has two layers. You have the fibrous and the serous layer. The fibrous layer is the outermost layer, and this not only serves to cover the heart, but also it will keep the heart in place by attaching anteriorly, by attaching to the central tendon of the diaphragm. And this is not anterior, because the anterior is the sternum. The central tendon is more of central tendon of the diaphragm, more inferior attachment. And the sternum, it will be through the sternopericardial ligament, in which the pericardium is attached to the sternum, and through a ligament, and to the great vessels of the heart, which will be anteriorly, superiorly, which are your aorta, your ascending and your descending vena cava. Superior and inferior as vena cava. Then the serous layer is the innermost layer of the pericardium. This is further subdivided into two layers. These two layers are significant in as much that it will help in the contraction of the heart. So your parietal layer is the lining of the fibrous pericardium. Then the visceral layer is adherent to the heart surface um, and is also known as your epicardium. Now, between these two layers, the parietal and the visceral layer is a cavity. This is just a slit-like space between the two layers of the serous pericardium containing tissue fluid acting as lubricant to facilitate the movement of the heart. So this is, you have to remember that the pericardial cavity is between your parietal and visceral layer, and in between that is a serous serous tissue fluid, and this will help as the heart will contract, it will not stick to the fibrous layer, to the parietal layer, but it will just slide down as it contracts. Now, the heart is described as a hollow muscular pump of the cardiovascular system. So, ladies, when somebody tell you that I love you with all my heart, you can tell that person or that guy trying to impress you that you are saying something that is a baloney, because you cannot. The heart is just a hollow muscular pump, and it belongs to the cardiovascular system, not to the endocrine, where it will tell you more of how much you love a person. Now, the heart is pyramidal in shape. You are very familiar with this whenever we express the heart, that it is pyramidal in shape. Now, it will be resting on the diaphragm, but it is tilted forward and to the left. Now, your heart is located within the pericardium, situated in the middle mediastinum. Now, this will be overlapped by neighboring lungs. So, your heart is below, anterior to the heart is the end, the medial end of the neighboring lungs, more on the left lung than on the right. Then posteriorly, it will be located anteriorly. You will have the sternum and the cartilages of the third and fifth rib. It has four surfaces. The heart has four surfaces, which would describe their location. The first surface is the anterior surface. This is also known as the sternocostal. So meaning to say, it is within the vicinity of the sternum and the costal cartilages. So what would be the part of the heart that would make up the anterior surface or the sternocostal surface? This will be formed by the right atrium and the right ventricle. So, since it is directed more to the left, so what is seen is the right atrium and the right ventricle. This will be bordered on the left by the left ventricle and on the right by the right atrium. Now, the inferior surface is the diaphragmatic surface. So this is where the heart will be lying. This is formed by the right and left ventricle and inferior surface of the right atrium. Then you have the base or posterior surface. Now the base, it does not lie on the diaphragm. It is more of behind the diaphragmatic surface. This is formed by the right and left atrium. This is the site where the great vessels of the heart will sprout. So your vena cava, your superior and inferior vena cava, and also the ascending aorta before it will become the arch of the aorta. Then you have the apex. This is formed by the left ventricle. This is directed downward, forward, and to the left. This is palpable at the fifth left intercostal space, 3.5 inches from the midline. So your apex is very significant for you as a doctor, as an examining doctor, because this is where you will listen for the heartbeat. So going forward, in your status now as a student, when you become a medical clerk and you are asked to examine a patient, and a very vital examination of the patient is the listening for the heartbeat. So how will you find this? Be decent in your maneuver, because you know it is at the fifth left intercostal space. Now for multiparous women, those who have had several multiparous women, those who have been lactating at the time of their first child to the succeeding ones. So this can cause a dropping of the breast. So covering the fifth left intercostal space. So what do? You have to tell your patient that, "Ma'am, I will listen to your heartbeat. Your heartbeat is somewhat like covered by your breast. So do not manipulate on finding this fifth left intercostal space." So what you can do is put your stethoscope beneath the breast, the drooping breast, and move lateral till you will have the heartbeat. You can listen to it. So you have to be decent, you have to be respectful of the patient, especially if the patient is of old age already. Mostly kung teenager pati mo patient, be careful that you will not uh, accidentally touch the breast. So what you can do is use your stethoscope to slide towards laterally to find the fifth left intercostal space. And how will you know that it is the left intercostal space? Diba, when you talk, I was able to listen to Dr. Gasco during his talk on the bones of the thorax. The sternal angle of Lewy, you cannot determine the first rib, but what can be palpated would be the second rib by finding the sternal angle of Lewy's, then go lateral. The the bone that you will palpate next in line with your sternal angle of Lewy, that is your second rib. Remember? Then below that bone, that will be your second intercostal space. So going down, you will have the fifth left intercostal space. Now we go to the external feature of the heart. You have the coronary sulcus or the atrioventricular sulcus. So meaning from the name, It separates the atrium from the ventricles. There is a depression or a sulcus that will be seen there. This will separate the atrium and the ventricles. Now this sulcus will go around the heart. And this sulcus is an important important depression because this will be the course for the right coronary artery after it leaves the aorta until it descends posteriorly. So your right coronary artery will go posterior. And then your left coronary artery is just a small artery wherein it will give left circumflex artery branch, which will be the one which will be seen posteriorly. And this will ramify or have many branches. Then you have the interventricular sulci. So meaning to say, it separates the two ventricles, the two ventricles, and this will extend from the coronary sulcus to the apex. So from the coronary sulcus or the atrioventricular sulcus, that will be where your beginning of your interventricular sulcus, sulci, and it will reach to the apex or the inferior portion of the heart. There will be two in number lying opposite each other, two interventricular sulcus. You have an anterior interventricular sulcus which contains the left anterior descending coronary artery, while the posterior interventricular sulcus will contain the posterior descending coronary artery, which is either the terminal branch of the right coronary artery, because remember your right coronary artery will go posterior, or it could be your posterior interventricular sulcus could be a branch of the left circumflex artery, which comes from your left coronary artery. Then another structure is the crux of the heart. So crux, it means it is a junction of your coronary sulcus and the posterior interventricular sulcus. Internally, this is the point where the atrial septum meet the ventricular septum, and also the site where the coronary artery gives a small branch to the atrioventricular node. So this is the heart. So you can see this is the external feature of the heart. What you have here is the right ventricle, and then you have the left ventricle here, and the right atrium, and the left atrium. Now you have here the great vessels of the heart. You have the pulmonary trunk, this one, and it will divide to your left and right pulmonary artery, where it will go to the right and left lung. Then you have the superior vena cava and the inferior vena cava. You might wonder, and then you have your aorta. From the color, you can infer the content of the blood there, whether it is oxygenated or not. So the red one, the aorta, is oxygenated. Then the inferior vena cava and the superior vena cava, and the inferior vena cava, and also the pulmonary artery. Although it is an artery, it contains unoxygenated blood because this blood will still go to the lungs. Then we go to the structure of the heart. The structure of the heart, this is made up of the wall. There are three components of the wall. You have the epicardium or the visceral layer of the serospericardium. This is the outermost layer. Remember, I said earlier, your visceral layer of the serospericardium is also known as your epicardium. Then you have the myocardium, which is the cardiac muscular layer. Then the endocardium, which is the endothelial layer or the innermost layer of the heart wall. And of these three, the thickest layer is the myocardium. Then you have a septum dividing the atria. This is only a thin-walled atrial portion of the heart, and you will find it here, the embryonic fold in which blood will from the right atrium, it will go directly to the left atrium, then to the left ventricle. You have your fossa ovale there. Then you have the interventricular septum, which divide the thick-walled ventricular cavity of the heart. The interventricular septum is obliquely paced, in which there is a significant characteristic of the interventricular septum, wherein the upper portion is thin and membranous, and the lower portion is thick and muscular. What is the clinical indication here? Whenever there will be a defect in the septum, the septum is the septum that will be open, and there will be a left and right transfer of blood. It would usually, the defect will usually be seen. The interventricular defect would almost always seen in the upper portion because it's thin and it is membranous. We'll go back to that later. So you have here the fibroskeleton or the cardiac skeleton, which is a fibrous tissue framework for the attachment of the valves and the atrial and ventricular musculature and valves. So this you might say that the heart is deprived of skeleton. No, it's not. The heart has much as it is a more muscular structure. There is a bony, or no, not a bony, but a fibrous tissue that will serve as a skeleton for the heart. So there are four components of this fibroskeleton. You have the central fibrous body, the left fibrous trigon, the mitral or tricuspid annuli or annulus fibrosus, and the membranous ventricular septum. So this structure, the four components are attached to the atrial and ventricular musculature and valves, making it in place so that it can perform its function. So your central fibrous body or right fibrous trigon is found at the central portion of the heart. It is fused with the medial portion of the mitral, tricuspid, and the aortic valve. Then the left fibrous trigon, so you have the right fibrous trigon, then the left fibrous trigon, formed by the compact bundle of connective tissue that will course from the central fibrous tissue body to the left, posterior-inferiorly and anteriorly. So this will be connected to the right fibrous trigon. Then you have the mitral and tricuspid annuli, or the annulus fibrosus. So this is another fibroelastic tissue which is continuous from the right and left fibrous trigon. So from the right and left fibrous trigon, this will be connected, and this will partially encircle the mitral of tricuspid valve. So from the right and left fibrous trigon, there will be a circling fibroelastic tissue uh, encircling the mitral and tricuspid annulate valve. Then your fourth component is the membranous ventricular septum. This is the extension of the fibroskeleton from the right fibrous trigon. So this central fibrous body is basically the center of the fibrous skeleton, the fibrous tissue that will surround the heart, or that will be seen in the heart. Because your left fibrous trigon will be connected to the right fibrous trigon, your mitral and tricuspid annuli will be uh, will be attached to your right and left fibrous trigon, while your membranous ventricular septum will be attached to the right fibrous trigon. So this is the fibroskeleton. We go back. This is the cardiac skeleton. So you have here the four valves: the pulmonary semilunar valve, the aortic semilunar valve, and the bicuspid or mitral valve, and your tricuspid valve. And also you have the cardiac muscle of the right ventricle and the cardiac muscle of the left ventricle. So these are the structure which will be the attachment of the fibroskeleton of the heart. So the fibroskeleton presents as a form of a circular fibrous ring. It will be interconnected by your intervening fibrous tissue. Remember that your fibrous ring of the mitral valve will be the center for here, your right fibrous trigon here. All the other fibrous ring will be attached to your right fibrous ring, except for your mediastinal. It will only be for your right fibrous ring. So it will basically, this fibrous skeleton will be encircling will form a fibrous ring that will surround the three valves. So there is a connection of the four valves. Then you have other structure, which is your papillary muscles. These are located below the commissure of the atrioventricular septum, projecting from the trabeculae carneae or the ventricular wall, and would be attached to the chordae tympani, which function to prevent the valvular contraction from turning inside out during ventricular contraction by contracting also. So when the ventricle will contract, the papillary muscle will also contract to prevent the valve from turning inside out, or meaning to say, because it is contracting, it might push the mitral or the tricuspid valve towards the atrium. So this will be prevented by your papillary muscle. Then you have the chordae tympani, which are cords of fibrous tissue which connect the valvular cusp to the papillary muscle. We go back first to that. So these are your These are your valves, your tricuspid valve because this is the left ventricle, meaning right ventricle, sorry. And then this is your mitral valve because this is your left ventricle. You can see here, this is the chordate tendineae, and these are the valves. This is the papillary muscle. Now your your chordate tendineae will be attached to the valve and to the papillary muscle. So when there will be ventricular contraction, there will be closing of, of this flap of cusp of the mitral valve and the tricuspid valve. So when this will contract, this way the papillary muscle will also contract so that this will not flip inside out, meaning it will not go to the atrium. It will still stay there in the between the ventricle and the atrium, so that there will be no spillage of the blood being pushed by the ventricle. Then the cardiac valves, these are fibroelastic tissue also, which guards the orifice of the chamber of the heart. There are four cardiac valves. You have the semilunar, aortic, and the pulmonary valve. This is called semilunar because it is shaped like a moon, and there are three cusps for this aortic and pulmonary valve. This will guard the orifice of the aorta and the pulmonary artery and composed of three fibrous cusps. This will be situated at the summit of the ventricular outflow and surrounds the root of the aorta and pulmonary artery. So from this, you can imagine that the valve is it will be so this is a U-shaped convex lower edge of the cusp attached to the root of the aorta and pulmonary artery, and the free end protrudes into the lumen, so that when it opens, it will be towards inside the blood vessel, not outside, because free end will protrude into the lumen. Now, the vessel wall at the back of the cusp will protrude, forming the sinus of Valsalva, and at the center of the valvular free edge is a nodular interruption, the nodulus arante. These are only found, the sinus of Valsalva and the nodulus of arante will only be found behind the cusp of the aortic and the pulmonary valve. Then you have the mitral valve, which is a fibroelastic tissue attached to the annulus fibrosus that completely encircles the left atrioventricular orifice. So, mitral valve, left atrioventricular orifice. So, it is on the left side of the heart. And this is made up of anteromedial and posterolateral leaflet. So meaning to say, the mitral valve is a bicuspid valve. It has only two cusps. Now the orifice of the valve faces anterolaterally and direct atrial valve, the left atrial blood flow in an inferior, anterior, and lateral direction. Then your tricuspid valve, which is the valve on the right side of the heart. It encircles the right atrioventricular orifice and is oriented to its plane in a semi-vertical axis. It will direct the right atrial blood flow anteriorly and inferiorly and to the left. Now, there are three leaflets, or there are three cusps of the tricuspid valve. So you have an anterior cusp, which is the largest, and the posterior cusp, which is the smallest, and the medial or septal cusp, which may occlude small ventricular defect. When I read this, I remember my nephew-in-law, who is a nurse, who is now in America. He has a small mitral, uh, 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 not mitral, but valvular defect. So if one would listen to his heart very carefully and very long, there will be a punch, the you can hear a murmur. So during his, I remember him telling us during his physical exam prior to leaving to America. What he did was um, to take a deep breath while the examining physician was doing his auscultation of the heart. He hold his breath so that it might the murmur might escape the hearing of the doctor. Okay, we have the chambers of the or cavities of the heart, and this will be for the temporary storage of the blood. We have through four chambers, two for the left and two for the right. You have the right atrium. This will receive unoxygenated blood through your superior and inferior vena cava. This will just be as a temporary storage during ventricular systole. Ventricular systole or ventricular uh, contraction. So while the ventricle is contracting, the right atrium will be receiving blood coming from the superior and inferior vena cava. Now, what will you see in the right atrium? You have the sulcus terminalis, which is the ridge in the posterior external surface, extending vertically from the superior vena cava to the inferior vena cava, separating the main atrial cavity from the auricle. So your sulcus terminalis will be a border or a landmark to separate the main atrial cavity from the auricle, which is the ear-like structure of the heart, your auricle. Then you have your crista terminalis, which is an internal muscular bundle running along the edge of the entrance to the superior vena cava, then to the right side of the inferior vena cava. So your crista terminalis will just be a muscular bundle, but it will separate the blood that will come from the superior vena cava and the blood coming from the inferior vena cava. So this is the heart. You have here the the blood vessels. You have your pulmonary trunk. You have your your aorta. Then you will have the valves here. You have the tricuspid valve, which will separate your right atrium from your right ventricle, and the mitral valve, which will separate your left atrium from your left ventricle. So this is a sagittal section of the heart so that you can see the cavities and the and you can see uh, this is the valves. Then another structure is your sinus node. This is found usually at the junction of the superior vena cava, right atrium, and the right atrial appendage beneath or near the sulcus terminalis. Now, your sinus node is where you will find the SA node. The sinus node. So this is seen at the junction of the superior vena cava, right atrium, and right atrial appendage beneath the sulcus terminalis. So you will see this on the superior portion of your right atrium. Then you have the pectinate muscle, which is a parallel muscle bundle on the surface of the right atrial wall and the appendage or the auricle. So it will separate again the right atrial wall from the auricle. Then you have the Eustachian valve. This is an inconstant and rudimentary crescentic fold in the inferior vena cava opening. So this cannot be seen usually because it is rudimentary. It might disappear as one grows older. Then you have the torus aorticus, which is the right bulge. This is a slight bulge on the medial right atrium due to the presence of posterior non-coronary cusp and the right coronary cusp. So again, this is a muscular structure because it bulges on the medial right atrium. This is just a small portion because it will be near the cusp. Then you have the fossa ovale, which is the shallow depression at the center of the atrial septum. Your fossa ovale, this will be the entrance or this will be open during embryonic life, separating, allowing the blood coming from the right atrium to go to the left atrium without pass, because that is mainly if you will have the embryonic cardiac cycle, what will enter your right atrium will just be a small amount of blood because most of the blood will go from the right atrium to the left atrium, then go to the left ventricle. Then you have a Thebesian valve, which is another rudimentary flap of tissue guarding the orifice of the coronary sinus. So this is just rudimentary, so it may disappear as one goes older. Then we go to the right ventricle. The right ventricle receives blood from the right atria during ventricular diastole or relaxation. And it will propel it to the lungs during ventricular systole. So, during ventricular diastole or relaxation, blood will enter the right ventricle. But when it will contract, it will propel the blood that is found there in the right ventricle to the lungs through your pulmonary tract. This is the most anterior chamber of the heart, lying directly beneath the sternum. So you cannot hear the beating of your right ventricle because it will be covered by a sternum. Then this will be placed partially below and in front of and medial to the right atrium, but anterior and to the right of the left ventricle. The chamber is crescent-shaped with a thin outer wall. The right ventricle has a thinner outer wall compared to the left ventricle. So what are the significant structures that you will find in the right ventricle? This is the trabeculae carneae. This is a muscle bundle which lines the anterior and inferior walls of the ventricle, forming a ridge along the inner surface. So another muscular bundle. Actually, these muscular bundles, they are just point of separation in the flow of the blood that will be found there in that cavity. Then another structure which is significant only to the uh, right ventricle. This is your moderator band. This is a constant muscle which crosses from the lower ventricular septum to the anterior wall to join the papillary muscle. So your moderator band is a muscle which is constant and can be seen only on the right ventricle. Then another significant structure is the infundibulum. This is a smooth-walled outflow tract on the superior portion of the right ventricle. So this will be the, the tract that will be followed by the blood as the blood is being pumped to the lungs through your pulmonary tract. Then you have your crista supraventricularis. This is a thick muscle which separates the inflow tract. So you can see there is another vascular bundle that will separate the inflow tract or the blood that will come from the right atrium, separating it from the blood that will be pumped to your to the pulmonary tract. So that are the significant structure. Remember, your moderator band is only seen in the right ventricle, and this is a constant muscle. Then you have the left atrium. This receives blood from the pulmonary veins and serves as a reservoir of blood during ventricular systole. So while the ventricle is contracted, the blood that will come from the lungs will be stored temporarily in the left atrium. And when the ventricles will relax, it will contract also and push the blood to the left atrium. This is located superiorly, midline, and posteriorly. Now, the wall is thicker than that of the right atrium. So, comparing the two, the left and right atrium, the left atrium is thicker because it has to pump the blood to the left ventricle. Whereas in the right atrium, it will just receive the blood passively coming from the superior and inferior vena cava. Then you have the pulmonary vein which enter posterolaterally to the left atrium. There are 4 pulmonary veins, 2 for each left, 2 for each lobe of the lung. Now, your pulmonary veins opening guided by a sleeve of atrial muscle with sphincter-like function. The endocardium in the left atrium is smooth, and pectinate muscle is found only on the left atrial appendage. So another marker, your pectinate muscle. This is found only in the left atrial appendage. Then you have the left ventricle, which receives blood from the left atrium during ventricular diastole. So when the ventricles will relax, it will receive the blood coming from the left atrium And when it will contract, it will eject blood to the ascending aorta. Now, the left ventricle is bullet shaped with blunt tip directed anteriorly, inferiorly, and to the left, whereas your right ventricle is crescent shaped. Your left ventricle is bullet shaped. Now, this will be placed posterior unto the left of the right ventricle and inferior, infero-anterior unto the left of the left atrium. Chamber is ellipsoidal sphere surrounded by thick muscular wall. The muscular wall of the left ventricle is 3 times thicker than that of the right ventricle because you see the blood that it will pump will be sent to the whole of the body. So that's why it needs a stronger contraction uh, to 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 push the blood out of the left ventricle. Now, between the as to sizes, the left ventricle is bigger than the right ventricle. Now, the funnel-shaped inflow tract formed by the mitral annulus, mitral leaflet, and chordate tendineae with blood flowing inferiorly, anteriorly, and to the left. So again, there is a specific tract in which the blood will follow whenever there will be contraction, whether it is inflowing or outflowing. So when the blood will enter a cavity, it will not pass through the passage in which the blood that will go out of that cavity. They have a different road. But it is within the heart. It would be because of the presence of the muscular bundle. Now, the outflow tract of the left ventricle is inferior surface of anteromedial mitral leaflet, ventricular septum, and the left ventricular free wall. So that is the outflow tract. The inflow tract will be formed by the mitral annulus, the mitral leaflet, and the chordate tendineae. So you see that they have, even if they will go to the same chamber, they will have a different track whether they are going out or going inside the chamber. So this is the external portion of the heart. You have here the right ventricle, the left ventricle, the right atrium, left atrium, I mean, and you have the right atrium. Then you have here the superior and inferior vena cava and the pulmonary trunk, and also your aorta. You have the interventricular septum here, and the you have here the right coronary artery. So you know that the right coronary artery courses through the coronary sulcus. So that will be your coronary sulcus. So you have the arterial supply of the heart. Now the arterial supply of the heart, before when I was still in high school or younger, I thought that the heart that is, the blood that is received by the heart is, uh, will supply the heart itself. No, it's not. The, the arterial supply of the heart will be different to the blood that will go into the heart for pumping to the other areas, to the lungs, to the systemic system. they will be just for storage. But this one, the heart supply of the heart, will supply the muscles of the heart. So your arterial supply of the heart is made up of um, end arteries. If you remember and if you read your Snell in the uh, introduction of the introduction of the introduction of the blood vessels, there was a mention of types of end arteries. There are two types. I want you as to answer me. What are the two types of end arteries, and what to which does the arterial supply of the heart belongs to? What kind of end arteries? You have to know that your your the blood vessels of your heart are end arteries. So you differentiate what are the two types of end arteries and what is the type of end arteries does the heart have. So that is your question and you have to answer that for attendance. So you have the source of the arterial supply of the heart comes from the ascending aorta. I have already mentioned to you that you have the right coronary artery and the left coronary artery, in which the right coronary artery is bigger and longer, whereas your left coronary artery is just short and will give out its terminal branches, already. So your right coronary, let's go first to the right coronary artery because there will be anastomosis, massive anastomosis between the two arteries that will come from your ascending aorta. So your right coronary artery will enter your anterior aortic sinus. It will course down from the ascending aorta between the right auricle and the pulmonary trunk. And it will course through your anterior interventricular groove. Now, as it courses you in your anterior interventricular groove, it will branch out, or it will give branches to the right atrium and the right ventricle. Then it will go around and go to the posterior interventricular groove. And there, it will give to another branch, your marginal branch, and your posterior interventricular branch. So we go now to your left coronary. Let's not go first to the anastomosis. Let's go to the left coronary artery, which arises on the left posterior aortic sinus. It will be seen between the pulmonary trunk and the left auricle. And it will also enter and course through for a short period of time, the anterior interventricular groove. Then it will give a branch, which will be the one which will course longer through the heart. You have the circumflex branch and the anterior interventricular branch. That is as it will branch out from the left coronary artery or circumflex branch, and your anterior interventricular branch will branch out from your left coronary artery before it will go to the posterior interventricular groove. So these branches will go to the posterior interventricular groove. Now we go to the anastomosis. There is a massive anastomosis between these two arteries and its branches. So what does it mean? So it means that if ever there will be block, there will be other options for the heart to go. Although they are of different sizes. So lucky you if you have a stroke or you have an infarction that will involve only a small artery, because it can be compensated by this anastomosis. So your right coronary artery will directly um, anastomose with a branch of your left coronary artery, which is your circumflex branch. So there is an anastomosis between the right coronary artery and your left coronary artery through your circumflex branch of the left coronary artery. Then your left coronary artery will also have an anastomosis with the branches of your right coronary artery through your marginal branch and the posterior interventricular branch. And your posterior interventricular branch will also anastomose with the circumflex. Remember that your posterior interventricular branch is as a branch of your right coronary artery, and it will anastomose with a branch of your left coronary artery, which is your anterior interventricular branch. So these two our anastomosis comes from the right coronary artery, your posterior interventricular branch, and from your left coronary artery, your anterior interventricular branch. So the anastomosis is between the branches of the right and left coronary artery. There is no direct anastomosis between the right coronary and the left coronary artery. It will anastomose with a branch of each other. So I want you to answer that question, my question. What are the two types of end arteries? This is an end artery. And what type does the arterial supply of the heart belong to, of the two types of end arteries? So that's why if you have cardiac infarction, or there will be the supply of the blood supply of the muscles of the heart will be hindered or blocked by block, and this could lead to what you call as heart attack. So it could be because the anastomosis is not sufficient for it to supply the blood, the muscle that is blocked by the, or where in which its supply has a block. We go to the venous drainage of the heart. The venous drainage of the heart will all end up in the right atrium. But there are three in which it will go first to the coronary sinus before it will drain into the right atrium. So you have the great cardiac vein, the small cardiac vein, and the middle cardiac vein draining first to the coronary sinus before it will drain to the right atrium. But the anterior cardiac vein and the other small veins will directly drain into your right atrium. So the nerve supply of the heart, this is interesting because the nerve supply of the heart comes from the autonomic nervous system. It has both a sympathetic and parasympathetic innervation. The sympathetic innervation of the heart comes from the cervical and upper thoracic portion of the sympathetic trunk. It has different afferent fibers, but it shares the same efferent postganglionic fiber. So the afferent fiber from your sympathetic nerve supply of the heart normally do not reach the level of consciousness except during infarction or heart heart attack when pain is felt. So you do not feel normally. You do not feel the pain in your heart. So once you feel the pain in the cardiac portion of your chest, you might wonder, is this already an infarction? Is this, am I being told that I'm having a heart attack? Whereas your afferent innervation for your sympathetic nervous system, it will be aided by the vagus nerve. So parasympathetic, so it is for relaxation, and this will the participate in cardiac vascular reflexes. So when you have tachycardia or when your heartbeat goes down, so it will be under the influence of your parasympathetic or your vagus nerve. Your parasympathetic, aside from your parasympathetic efferent, just like your sympathetic efferent postganglionic fiber, they will go to the sinoatrial node and your atrioventricular node, the coronary arteries, and the nerve plexuses. We'll go to the action of the heart. Here, there is a contraction of the cardiac muscles, and it will initiate the cardiac cycle, which is the alternating event of ventricular systole or contraction and ventricular diastole or relaxation. Now, the cardiac cycle has 8 phases, named after the activity of the chamber of the heart as exerted by the cardiac muscle. Although in your book, you can see that this is tabulated. The phases of the cardiac cycle against the event that is happening on the left ventricle. So you can see that in your book. So your isovolumetric contraction marks the beginning of the ventricular contraction. Specifically here, what is being discussed is on the left ventricular contraction. There will be a steep rise of ventricular pressure augmented by the closure of the atrioventricular valve. So the valve that will separate your atrium and your ventricle will be closed, so that there will be a building up of ventricular pressure, while the auricle or the atrium will relax. This will be followed by the maximum ejection. This will commence with the opening of the aortic valve, followed by a rapid ventricular injection of blood, accounting for the greater part of the outflow. So, what is happening to the pulmonic valve? It will occur also during maximum ejection, because your left and right ventricle will be contracting at the same time, with the left ventricle by millisecond will contract first. So here in maximum ejection, the ventricles will be emptied through your aortic valve so that blood will flow to the aorta. So during this phase, what is happening to the atrium? it will start to build up also a pressure, a certain pressure, because when this will, it is preparatory to the ejection of blood coming from the left atrium to be pushed to the left ventricle when it is already empty. So reduced ejection, there will be gradual halting of blood flow from the ventricle. So it starts to be empty. Then protodiastole is the interval just prior to aortic valve closure when the ventricular outflow ceases. So this is a very brief phase, your protodiastole, wherein your aortic valve will close and ventricular outflow will cease or stop because there is no more blood that will come out from it. Then you have the fifth phase, your isovolumetric contraction, relaxation, I mean. It marks the beginning of ventricular relaxation with the beginning of closure of the aortic valve and opening of the atrioventricular valve. Thus, ventricular pressure will fall rapidly. Incisura in aortic pressure curve is seen at the beginning of this phase. Then this will be followed by rapid filling because the atrioventricular valve will open, followed by a rapid flow of blood into the ventricles, filling the ventricles occurring chiefly during this interval. Now, the reduced filling declines of ventricular filling. Then you have the eighth phase or the last phase is your atrial contraction. Here, the ventricle will be completely be filled with blood, and atrial contraction followed immediately by onset of ventricular contraction and beginning another cycle. Now we go to the conducting system of the heart. It has four components that will play a role in the conduction of the signal of the heart to contract. So you have your sinoatrial node. This is also the pacemaker of the heart because it will regulate the beating of the heart, whether it will be tachycardic or it will slow down. So this is also known as your SAN or atrial node. This is located in the upper part of the sulcus terminalis to the right of the superior vena cava orifice. Then you have the atrioventricular node or your AVN. This is found in the atrial septum, lower part of the above attachment of the septal cusp of tricuspid valve. Then you have also the atrioventricular bundle. It's found in the septal cusp of the tricuspid valve to the membranous part of the interventricular septum. And this will divide into right and left bundle branch. Then you have the smallest of these fibers, your endocardial Purkinje fiber, which will be distributed to the ventricles, more on the left than on the right. So you have it here, you have your sinoatrial node or the pacemaker of the heart. Normally, all signals should start from the SA node. Then it will be distributed down to the middle internodal tract, to the posterior internodal tract found in the atrium, in the right atrium. Then you have here the signal from your SA node could also go to your left atrium through your Bachmann's bundle. Now, most of the signal will go to the atrioventricular node or your AV node, which will be distributed by your AV node to your um, bundle branch or your uh, interventricular bundle. Then it will separate to your left bundle branch and the right bundle branch to go to stimulate the left ventricle uh, for the left to your left bundle branch and your right bundle branch to your right ventricle. Then this bundle branch will give smaller uh, branches through your and will serve as your conduction pathway. This is now the your so-called Purkinje fiber. So this is your endocardial Purkinje fibers. It will be spread throughout the ventricle so that there will be enough signal for its contraction. Now the function is to generate rhythmic cardiac impulses and rapid conduction of impulses throughout the myocardium for coordinated and efficient manner of contraction. Now the conducting system of the heart will have its own blood supply. So for your SA node, right and left coronary artery. While your AV node, which is smaller, will only have a blood supply coming from the right coronary artery. Your AV bundle will come from the right, the blood supply will come from the right coronary artery, while the right bundle branch will have a blood supply from the right coronary artery and the left bundle branch from the right and left coronary artery. Autonomic nervous system will influence conduction of impulses, wherein sympathetic, it will increase the rate of conduction and faster rhythm. So that this is when you are frightened or when you have a tachycardic condition of your heart. Your parasympathetic, there will be a decreased rate of conduction and there will be slow rhythm because there is your parasympathetic autonomic system will give a relaxed condition. So I think that's all of my lecture for today. Thank you, and may you be able uh, to understand this. I have given you an enlightenment of what is being said. Okay, thank you for listening, and I hope I have given you. And let me remind you, please, please answer what I have asked you regarding the type of blood supply of the type of blood vessel of the heart.